program that we have here at Lakeland. We are general surgeons. Dr. Clancy. We have Dr. Kline, Dr. Jeffers, and Dr. Winslow. They're also going to give some presentations for you. Everybody get a chance that wanted to practice on the robot before? Raise your hands if you got to play with it. So Brian, shout out to Brian, he's our intuitive representative. So they're the company that makes the robots and they service the robots for us. He will be staying here afterwards, so if you would like to play with it afterwards, that'd be wonderful. And a shout out for our Average Joe representatives. We have two students from St. Joe High School that were on the Average Joe robotics team, and we have a mentor over there. And the lady next door was also on the Lancebot team, which is the Lakeshores team. And back at the World Championships in Detroit, they ended up being on the same team, and they were the finalists in their division, made it to about the top 12 in the world before they got eliminated. So we're here to talk about what is robotic surgery. That's kind of the theme of this. And after I give a brief presentation about the differences between open surgery, laparoscopic surgery, and robotic surgery, we're going to have a talk on colon surgery, on reflux type surgery for like gastroesophageal reflux, hiatal hernia, and then we may touch base with some gallbladder surgery and hernia surgery, and then we'll be available afterwards to answer some questions. Lakeland, we've been a fair leader in robotic surgery in the state of Michigan for a long time. Our urologist, Dr. Stockton, is a fellowship-trained urologist on robotic surgery, and back in 2012 when he joined us, Lakeland had a robot forum to kind of launch our program. In May of 2013, Dr. Winslow and myself were approached to see if we were interested in doing some robotic surgery in the general surgery department. And in May 2013, we started doing gallbladder surgery, and as you'll see, it blossomed, and we're doing lots of different types of robotic surgery now. Some highlights: 2014, we got the first XI system, or the second XI system in Michigan. This is the third generation robot that Lakeland purchased. In 2016, we got another one. We planted it here at the COP Center, and we started doing outpatient surgery. We were the first in Michigan to do that. Lakeland has 3 robots, one in Niles, one here in this building, and one at the main hospital. Again, we started with 1 or 2 surgeons in urology, GYN, added general surgery, and now we have 17 trained robotic surgeons at Lakeland, providing a wide access to lots of different specialties. And to date, we've done over 3,000 surgeries on the robotic platform. This is the list of general surgeons in our community. Dr. Bates, Dr. Gorsuch, Habenik, and Dr. Schutnick are based in Niles. And myself, Dr. Jeffers, Dr. Kline, Dr. Webb, and Dr. Winslow, we're based here in St. Joe. We operate here at the outpatient center as well as at the hospital. Here's some of the other surgeons in the different service lines. So the bariatric, that's for surgery for weight loss. Dr. Gorsuch and Dr. Schutnick are specialists in that. Dr. Bagalai does cardiothoracic. He's mostly just doing lung resections. There's really no cardiac stuff. I don't think there's anything that's going to be launched anytime soon for that, but the minimally invasive pulmonary resection. We have 4 excellently trained GYN surgeons, and then Dr. Stockton.
They have bariatric surgery here?
The bariatric surgery is based in Niles. So no, the surgeons that do bariatrics don't come up to St. Joe at this point in time. I do not. I don't believe that's in the plans as of now.
So you don't do that?
No. Those are fellowship-trained surgeons, so it's an extra training beyond the general surgery residents. We're here to talk about what robotic surgery is. So there's basically 3 types of surgeries that we do. We do open surgery, we do laparoscopic surgery, and we do robotic surgery. So if you put them in 2 different piles, the open surgery, in the operating room, the surgeon's going to be standing at the bedside. He's going to be making an incision wherever he needs to make the incision. He's going to be touching you using instruments, There'll be an anesthesiologist there. Laparoscopic surgery is similar, but it's minimally invasive. So it's similar to the robot, but it's also similar to the open because the surgeon is going to be standing right next to you for the surgery. He'll be touching you, he'll be using instruments, and he can actually feel you. Be an anesthesiologist there taking care of your anesthesia. With robotic surgery, it starts off as laparoscopic surgery, so we put the access ports in and put the camera in there, but then the surgeon is going to step away from the patient and he's going to go over to the console and he's going to make the robot do what he needs it to do. So how does it work? That's our robot. So when we're all set up, we push a button, all these lasers come out, and the robot starts going crazy, and we all freak out, we run away, and we come back, the operation's done. No, that's not how it happens. However, I will tell you though, autonomous robotic surgery is in the pipeline. Some of the breast biopsies that are done, some of the radiological imaging stuff that is done, the GPS surgery that the neurosurgeons use, that is autonomous, robotic surgery. The surgeon's not pushing the thing in. This is coming, not going to be in my career, but I imagine in 20 years from now, because 20 years ago when I started, that robot wasn't available. 20 years from now, it's going to be completely different. So that's kind of exciting. This picture shows basically how it's done. Over on the far left, after we've gained access to your abdomen, and we decided that robotic surgery, and we're going to proceed with it, we usually have 1 or 2 assistants there, and their job is to assist the surgeon at the bedside to put the instruments on the robot, take them out. Sometimes we have to sew to put sutures in there. The surgeon is sitting down 10 feet away, 15 feet away, 20 feet away. If you had a cable that was a mile away, we could be a mile away if the internet was fast enough. The robot does not move unless my hands are in there and making those arms do what I want it to do. In the middle, there's the little glasses that we put our head into, and that's how we see. When we do laparoscopic surgery, we're looking at a television screen. In the operating room, there's lots of television screens, so I'm seeing it in 3D, and on television screens, depending on the monitor that we have, the team in the operating room is also watching it, so they can see what we're doing. The nice thing about the robotic surgery versus the regular laparoscopic surgery is the instruments. My hand moves in lots of different directions. It's got 7 degrees of motion. When we do laparoscopic surgery, the instruments go in and out, they can rotate, and the jaws open up. But the big thing with the robotic surgery is that wrist of movement. And that makes the fine details of the surgery much easier, so we can do more complex surgeries that way safer. The endoscope on the robot is in 3D. So when I'm looking, or when you're looking in, playing on the machine, you can tell that there's depth perception. So that's important. You know, we trained ourselves to do it laparoscopically where you don't have the depth, but that depth is kind of a game changer. It makes the surgery a lot safer. You can get around vessels easier, you can see relationships to things, and it's all about the anatomy. If we see something that we know we don't want to that we want to stay away from, if we know that it's a millimeter behind, or 3 millimeters behind, or a centimeter behind, that's much easier to dissect that out to safely versus we know it's there, but we don't know how far back it is. There's another picture of the robot. The nice thing about the Xi platform versus the one we had before, that allows us to basically get anywhere in the abdomen. We can look up, we can manipulate the cameras, and we can get down, so we can kind of, for colon surgery, what Dr. Jeffers going to talk about, we can basically start over here on the left side and just kind of keep working all the way around. So that was the nice advance when we went from the SI platform to the XI. Again, the surgeon's controlling all the movement, the 3D high definition. So some laparoscopic surgeries have 3D. The nice thing about laparoscopic over the robot is what we term haptic. So I can feel it. So if you have like you're going fishing, you can feel the fish pulling on that. You can feel that with laparoscopic surgery. You don't feel that with the robot. So your eyes, with the fine detail, you kind of sense that you might be stretching something, so you learn a little bit different. And then as we get doing more complex operations, the computer on the robot, we can adjust it so it can scale movement. So my hand moves 3 centimeters, I can adjust it so the robot only moves 1 centimeter, so it can do much more fine detail like vascular anastomosis or bowel anastomosis. So I think that's important for some of the more advanced surgical procedures that we do. The one thing that I really think is an advantage, at least in my standpoint, when we did laparoscopic surgery, sometimes you have to look back at yourself. And when you aim the camera back, everything's upside down and flip-flopped. And when I'm thinking I want to move it that way, it's going the other way. So sometimes I would have to kind of close my eyes a little bit and say, all right, I need to move my hand this way, and then I would look. With the robot, you can change the computer setting to do that for you. So when I move my hand that way, the instrument's moving exactly where I want. So that's a nice advantage for that, for getting in as we're moving around. These are a good representation of some of the surgeries that we do at Lakeland. In bariatrics, they do the sleeve gastrectomies. They're doing the gastric bypasses. Again, those are only done in Niles. We have 2 trained surgeons down there. The GYN doctors are not doing oncological, not cancer operations, but they're doing hysterectomies and pelvic organ prolapse. Our general surgeries, we're going to learn about colorectal resections. We're going to learn today about reflux surgery, gallbladder surgery, hernia surgery, kidney removal. That's usually over on the urology side. Dr. Stockton does those. He does partials, he does totals, he removes the prostate, and he's even removed some bladders and did some bladder cancer surgeries here and there. That's all I have for the initial presentation. I'm going to have Dr. Kline come up and talk to you guys about reflux surgery and hiatal hernias.
Okay, thanks, Jamie. Can you all hear me? Everybody can hear me okay? I just want to thank you all for coming out. I know there's lots of other places that you could be, and so thank you for joining us tonight. And hopefully this will be a time when you can learn about robotic surgery and get to ask us some questions and see our robotic platform up close. So, high school students, thanks for being here. If you're from the robotic teams, it's really neat to see technology like this making a difference in people's lives. And so we hope that you join forces with Intuitive and get to help us make the next generation of robotic surgery. So, like Dr. Clancy said, my name is Dr. Craig Kline. I'm going to talk today about gastroesophageal reflux disease, the heartburn, and hiatal hernias, and what the robot can do to help correct these problems. How can the Da Vinci robot help me? Well, as many of you know, there's a tube from our mouth that goes onto our stomach called our esophagus, and that's a muscular tube, and it actually helps to propel food after we eat it down towards our stomach. And the esophagus also helps to close off the top of the stomach with a circular muscle called the sphincter, so that all that acid that's in our stomach doesn't have a chance to reflux up into our esophagus and cause us heartburn. So reflux, which is also known as gastroesophageal reflux disease, or GERD, a lot of you have probably heard of that term before, happens when our bodies cannot prevent acid from washing up into the esophagus, okay, like it normally should. And this can be the result of foods that we eat, or even how we eat them, our body type, or even hernias in our diaphragm. That's what's called a hiatal hernia. Many of you may have also heard that term, and we'll talk about that in a little bit too. So how does reflux feel? Well, it's kind of typical heartburn symptoms. It can cause pain right here, just underneath your rib cage. Some people describe a brackish water kind of taste in their mouth. And it can also lead to recurrent pharyngitis or sore throats, or even reactive airway disease like types of asthma. That can all be from types of reflux. And there's some risks associated to reflux. It's not just the pain. Lots of people take acid-blocking medications, such as H2 blockers or PPI. Some of you may know what those terms mean. But long-term use of those medicines, not only is it expensive, but it can lead to some side effects. So with proton pump inhibitors, it can lead to osteoporosis, especially in women. Long-term use can also cause some mental side effects. And also it can lead to Barrett's esophagus. You can see this little nodule in this person's esophagus. Well, that is actually esophageal cancer, which results from long-term reflux damage. And that's also can be a side effect of gastroesophageal reflux disease. So it's not just the fact that we want to get rid of the heartburn, but we want to reduce some of these risks that that can be associated with heartburn. So what foods cause reflux? All I did for this slide is just listed all the stuff that I love to eat and drink. Okay, so caffeine. Caffeine relaxes that sphincter and makes it easier for the acid in your stomach to reflux into your esophagus. And anything, not just coffee, but we're talking about chocolate, tea, anything that that has caffeine can cause that. High-fat foods or fried foods. Spicy foods, garlic, onion, pepper, can all lead to reflux. Alcohol, especially red wine. Okay, citrus fruits and citrus products, tomatoes, peppermint. These are all just not an exhaustive list, but some of the things that can cause reflux. You guys already know that. You said, I already know it, but all those things give me heartburn. Can my diet cause reflux? Yeah, absolutely. It's not just what we eat, but how we eat. So if we eat a big meal, it increases the pressure in our stomach and makes it easier for reflux to happen. If you eat large meals, or if you eat laying down, okay, you're on the couch watching TV, you're snacking on something, well, when you lay down, obviously it's easier for things to wash into your esophagus. So eating just before or during periods when you're laying down can make it easier for food to reflux into your esophagus. So what's a hiatal hernia? Well, there's also anatomic reasons why reflux can occur. There's a hole in our diaphragm that's called a hiatus, and that allows our esophagus to poke down into our abdominal cavity. And over time, your stomach can start to protrude up through your diaphragm into your chest cavity, and that's what's known as a hiatal hernia. Some people can have reflux without hiatal hernias, but in reality, most people that have reflux usually have a small hiatal hernia. And so that's another reason it can lead to reflux. Other factors, pregnancy obviously can lead to reflux, obesity, smoking, because smoking can increase acid production, decrease saliva, and it can damage mucous membranes and again decrease that lower esophageal sphincter, that muscular area, and make it easier for reflux to occur. There's also something that I should mention called a paraesophageal hernia. This is like a hiatal hernia on steroids, and many people have this. This can be where a large portion of your stomach, or even all of your stomach, can actually be up in your chest cavity. Sometimes other organs, like your spleen or your colon, can also be up in your chest cavity. So these are also hernias that can cause reflux, and also hernias that we can fix with the Da Vinci robot. Okay? So how in the world can surgery help me? Well, obviously we want to do our due diligence, and if we can save you from needing an operation, we want to do that. So all those foods that you and I love to eat, try to cut those out, try to change the way we eat. If that's not working, then we can offer surgery. And what does surgery do? Well, first of all, that first top picture you can see, we are closing that hole in the diaphragm if it's present, and closing it to what its appropriate size should be. So we pull down the stomach to where it should be, all in your abdominal cavity, and then we sew up that diaphragm so it's the right size. And then most of the time we also wrap the stomach around itself. This has a fancy name called the fundoplication, but it just helps to increase the resting pressure of that area of your esophagus, so it's harder for foods to reflux up, but it still allows you to eat like normal. Okay, and that's our goal of what we do during surgery. So how in the world can the Da Vinci robot help me? Well, Dr. Clancy just gave an excellent overview of some of the benefits of robotic surgery, so I'm just going to repeat some of that now. So in the past, we did these open, and it was done through a very large incision on your abdomen. Okay, not only did that cause a lot of pain, it could lead to hernia formation, and it was a longer stay in the hospital. And then we started to do these operations laparoscopically through tiny incisions, but it was a difficult surgery. Didn't have the wristed instruments like we have now with the Da Vinci. It was a long surgery, technically difficult, and when we say technically difficult, what that means is sometimes it was incomplete. There's little parts of the operation that we really wanted to do to make sure that we did everything, but it was too technically difficult to do. And so patients were really getting suboptimal operations with straight laparoscopic surgery. So what the Da Vinci Xi system allows, and I always tell people we have the most advanced robotic platform available anywhere in the world, right here in St. Joe. And so what that robot allows us to do, 3D visualization of your abdominal cavity in high definition. Okay, it allows us depth perception that gives you greater safety during surgery, and it also allows us better visualization. Wristed instruments allow for complex movements during surgery, that can not only keep you safer, but allow us to do a more thorough and complete operation in a shorter amount of time. Less time on the operating room table and less time in recovery, because again, we're doing this through small incisions. And we still are maintaining a minimally invasive approach, okay? What can you expect if you are going to have surgery on a hiatal hernia or for a reflux disease with a Da Vinci robot? Well, the first thing is that we want to do a thorough workup. Lakeland has just started a reflux clinic, and we do this in conjunction with our gastroenterology colleagues. We want to make sure that we're doing the right operation for you. So there's going to be some tests that we would want you to do. That includes an upper endoscopy and probably an acid test, something to prove that you are having reflux, and also a manometry test to test the resting pressure of your esophagus. These are tests that we do as an outpatient. And when you come in for surgery, surgery lasts between 2 and 4 hours. It's an overnight stay in the hospital. It's usually about a week of a liquid diet. I say a liquid diet is anything that you can pour. And after that, you can eat like normal. And usually it's a week off of work. And that's kind of the general template of what you can expect if you're going to have a robotic surgery. And if you have any questions about this surgery, all of the robotic surgeons here perform this surgery, so you can ask any of us. And we would love to help you out if you are suffering from reflux disease. We'd love to talk to you about how the Da Vinci platform here at Lakeland can help you. So thank you. I'm going to turn over to Dr. Jeffers, who's going to talk about colon cancer, or colon surgery.
Hello, everyone. Good evening. So we also use the robot for colectomies. So that is, we'll go over a little bit about that, and as well as all the things my partners and colleagues have shared with you. So what is a colectomy? A colectomy is removing a portion of the colon or rectum, and it's performed for colon cancer, for unresectable colon polyps or large colon polyps. If you've had a colonoscopy and they've removed polyps, sometimes we can't remove them during an endoscopy. Diverticular disease, inflammatory bowel disease, these are just a few reasons why we might need to remove part of your colon. What is a colectomy? On here on the screen, you can see there's different, your colon starts on the right side where it's connected to your small bowel, goes all the way around, kind of goes all the way around your abdomen on the outside, and then goes down to the rectum on the bottom. And so we can remove different portions of the colon for different areas of disease or different problems. We can remove the right side. This is called the transverse colon, the descending colon, the sigmoid colon, and then the rectum. This is just a picture just to kind of show the different areas of the colon that we can remove for obviously different reasons. So when we talk about colectomies, again, like the other providers have mentioned, there's open surgery and minimally invasive surgery. The minimally invasive surgery includes laparoscopic or robotic assisted. It has multiple little scars as opposed to one large scar for a traditional colectomy. And again, the surgeon controls all of these devices with the Da Vinci, so it's not like you're having the robot magically perform a colectomy at this time to do that. What does that look like? As some of you may see yourself or one of your friends, a large scar going up the middle of the abdomen for traditional open surgery compared to small little incisions, as you see on the other display. And some people may have seen people who've had gallbladder surgery or other laparoscopic surgery, and sometimes those scars can fade to quite small and maybe even not be able to see them in our normal body. Special considerations. When would we choose to do this laparoscopic robotically or robotic-assisted laparoscopic versus doing it open? What do I need to consider? What previous surgeries you've had. If you've had a lot of other previous surgeries, there's a high risk for having scar tissue and other things that may make the robotic more challenging or not possible and not safe for you. So we'd want to consider that. Previous scar tissue in the abdomen, other medical conditions that may affect the surgery. So you want to ask your doctor if minimally invasive surgery is right for you. It is something that's a collaboration between you and your physician to determine what surgery is correct for you and that'll be best beneficial. Minimally invasive surgery has been proven to be beneficial in colectomies. How has it been beneficial? It's reduced pain after surgery, quicker return of bowel function, lower rate of complications, shorter hospital stay, and minimal scarring due to smaller incisions. So with this, in the traditional open, where you have a large incision, we put our hands in there, move everything around in order to remove a portion of the colon, put the colon back together. We've noticed that people tend to have a lot of scar tissue. The bowel, when you manipulate it, tends to slow down. I tell people it kind of goes to sleep for a little bit and then gradually wakes up. That sometimes can take a few days after surgery, actually, doing an open surgery. When we do it minimally invasively, the bowel comes back right away, and you can actually see it on the console when you're in the abdomen. You can see that all the rest of the bowels are still working normally and moving things through as they should be. And that this eliminates some of that delay in recovery, which then, of course, lets you go home faster and get back to your normal life. Also, on the last one here is minimal scarring. I've actually done a number of these, and I have a patient that I recently took to the operating room for a second surgery, ended up needing a hernia repair after we had done a colectomy a year ago. And so you think, oh, you had surgery a year ago, especially a colectomy, that's a big surgery, where you're manipulating a lot of the areas of the bowel, putting the bowel back together. And as you can see here in this slide, it's not projecting very well, but I will tell you what you see in this slide. And that is, this is the abdominal wall up here, and then this is the abdominal contents. So you can see here the abdominal contents down here. This is one of our normal ligaments, and then here. And you can see how this bowel down here is all free from the upper abdominal wall. There's no scar tissue. We did a colectomy in this patient a year ago, and now a year later I had to go back for another reason. Incidentally, he needed a inguinal hernia repair. So, but when we went in, I didn't know if we were going to find a lot of scar tissue or not. But this is one of the benefits right here of why minimally invasive surgery is so beneficial, because that decreased scar tissue that forms afterwards. I've seen this time and again with people who've had laparoscopic gallbladders and we need to go in for some other reason, something else comes up later in their life, or patients who have had a laparoscopic appendectomy and, come down with appendicitis and you have the small little incisions to have the appendix out, and you go back in and there's not very much scar tissue, as opposed to people who've had large incisions tend to have a lot more scar tissue. Surgical benefits, as we've mentioned, in a lot of different variety of ways in all these different surgeries. That 3D view, increased visualization, increased dexterity, that movements, whether it's buying movements to dissect, the tissue very well, to see the tissue better, improve mobility of the instruments, increases our ability to perform oncologic, so that's cancer-related surgeries, as well as more challenging procedures. In colorectal cancer, so any colon surgery, some of those we're doing for colon cancer, and we want to make sure that we've got adequate lymph node evaluation. We have benchmarks that we look nationally to make sure we're reaching those benchmarks and make sure we're providing adequate surgery for patients, which we are. We're doing a great job, and this helps us do that so that we can get that better visualization, get that better look at those things, and better dissection that we could do previously. So it allows us to do some things that are more challenging. So another thing is diverticular disease. Some patients have where the colon, because of the inflammation in the colon from diverticulitis, I don't know if you've heard of friends or family who may have had that, diverticulitis can get so bad that the colon can attach to the bladder. And then it creates a hole between the colon and the bladder, which is bad if you're urinating things that should be coming out of the other side. So with that, what we have to do is we have to take down that abnormal connection and fix that up. And we can do that with this that we sometimes couldn't have done with just regular laparoscopic surgery, just because we have that better visualization and that fine dexterity of motions. Colon cancer treatment, minimally invasive surgery has been proven to have similar cancer recurrence, survival, quality of life compared to open surgery. So some people at the beginning, when we first started minimally invasive surgery, there was a question: are you doing enough surgery? Are you getting all of the lymph nodes that you need? Are you increasing the risk that the cancer will come back somewhere else? And studies time and time again have said that doing it minimally invasive is actually better in a lot of ways than doing it the open way. So we've not only been adequate, but we're better. So remember this, there are surgeons that are controlling these devices to best treat the patient and improve performance. So this is how we can help improve what we're giving to you and to make that better. And robotic colectomy is a safe procedure, improves outcomes compared to open colectomy. And I think that's the end of my slides, and I hope if you have any questions, I'm going to be happy to answer those for you. And Dr. Winslow is up next, talking about hernias and gallbladders. Thank you.
I think it's time to stretch, don't you? Stand up and Stretch your legs if you're able and want to.
Dr. Winslow,
Arms over your head.
your mic.
While you're standing there, I want you to think about what's the scariest thing about surgery. If we were to ask this room to give a poll, you can sit here ready. What are people afraid of when it comes to surgery? What's their biggest fear? What are the top three, you think? David Letterman used to have the top 10 list. Some of you stayed up late with me and watched those probably. Mine are probably not as humorous. They were scarier. But what are people afraid of when they're facing an operation? Anybody? Sorry? Not surviving, not waking up, right? Big fear. They don't tell us. I know that's often people's mind is, I might not wake up from this. Or, what else?
Complications.
Pain. During, afterwards, anytime, right? I mean, they may be having a painful condition. Some of those have been described today. Some of them I'm going to talk about. But they're really fearful how much pain they're going to have. And not only just they may not wake up, some people are afraid that they will wake up, right? They don't want to wake up during that operation and feel anything. And that's a very rare outcome. We're not here to talk about that tonight. But those are big fears. Not waking up, not surviving the operation, having pain afterwards. It's uncontrolled. They can't survive. Anything else people are afraid of? Complications, sure. Things going wrong. Worried about anesthesia, something going wrong, something with their heart, complication of surgery. Those are very common things. And then I have one lady who's an example of another concern, which is might leave something inside me. Right? This poor lady I met 3 different times last year for a condition that needed to have an operation. And she was just stuck on, I heard somebody had something left inside them before. And finally, she agreed that she was having too much pain, and after that, we tried to assure her if there's any one more additional advantage. You've heard a lot of them. Robotic incisions are really tiny, so it's pretty hard to stuff something in there and leave it behind. That's not the main reason for robotics, but we're not putting big sponges in there. The tools we put in slide in and out. Unlike when we open somebody up and put a bunch of things inside and have to drag it all out before we close them up, robotics are a little tiny incision. So. We're going to talk about some common conditions, and you've heard a lot about the robots already. But my theme is inside problems, which most of these deserve inside solutions. And most of us have grown up personally having surgery or having a relative or friend that's had surgery, and they may show you their scar. I remember as a kid hearing about President Lyndon Baines Johnson, if I remember him, on TV at a press conference, opening a shirt and showing his gallbladder scar to the world because he had this great big gash, which maybe somebody in this room is not going to show me tonight. So that was pretty common. You have a great big incision to get inside with our hands and do those operations. And that's the biggest difference is we're going to do stuff on the inside that deserves to be fixed inside with as minimal, opening, scarring, or trouble on the outside. And we want people to stay active, pain-free and active after a hernia repair or gallbladder, two of the most common conditions we treat, which I'm here to talk about. So we won't go into robotic details, but I want you to notice my tie. Anybody see that symbol on this tie? Anybody know what drawing that is? Da Vinci. That's one of Da Vinci's earliest drawings. So this company's named Da Vinci, and Da Vinci, if any of you are art students or art scholars know more than me, I finally had the chance last year to go to Italy, a lifelong dream of mine, to see some works of Da Vinci and Michelangelo, and I can't wait to go back. Totally amazing. You know how young those guys were when they got started? Where's my students? Anybody know what the age was of Da Vinci when he made his first drawing? Was frame? Any guess? He's 21. So at age 20, he's already named a master of the Guild of St. Luke. You know what that was? The Guild of St. Luke was 2 different professions, artists and doctors of medicine. Because if you remember from the Bible account, St. Luke was perhaps one of the earliest known physicians who wrote the story of Jesus' life. So St. Luke, with the Guild of St. Luke, Da Vinci was a member of at age 20, and he was apprenticed by the artists. Michelangelo, another of the greats. Anybody ever seen the Pieta in Italy? I was in the World's Fair at age 9, 1964, and walked through this long line at the Italian pavilion to see the Pieta. They had brought the Pieta from Rome. I don't know how they could have justified it. They would never do that now. And had it on display there. We saw that amazing sculpture of the Pieta with Mary holding Jesus in her arms. That was completed by Michelangelo at what age? Anybody know? Incredible detail, lifelike. You can see the feeling in that sculpture. He's 25 when he finished that amazing sculpture, never rivaled by anyone. So these are young people like some of you here in this room who are amazing artists. And Da Vinci I love because he was a scientist, an anatomist, an engineer, designer, an inventor, put all that stuff together, and a lot of it came from his early study of math, the human body, and all those things, which to me is a great reason. I'm not even a Da Vinci salesman, but I sound like one tonight. But that's the beauty of this instrument is engineers and artists and scientists and physicians and nurses working together to make this incredible thing work for people. So small incision, great decision. That's what we like to say. An early study that's not been published yet shows that patients remember having less disruption of their activity and less use of pain medication after robotic-assisted surgery, repair a hernia compared to open surgery. I'm not going to go into details of that tonight, but after 1 week, over 80% of people were taking no pain medication after those operations. And that's changed a lot if you know what's like that hernia operation. A lot of people are very limited. It used to be 6 weeks or 8 weeks before you go back to work. We have people go back to work as soon as they're pain-free, often within 3 to 5 days. And a lot of people put off their repairs. Their hernia repair, suffer with the pain or the bulging, discomfort, distress, or their gallbladder problem because they can't get out of work. Kids are in school, they don't have time off, they can't do it now, they're going to be off work for too many weeks. And we want you to stay active. It's all about time. We say it's about time that we had a tool like this. We've been waiting for this for a lot of years, but it's about your time. So rather than having to wait till next winter or wait till you've got a break in your work schedule, the next outage you cook, you know, this is saying you can get your surgery done and get right back to work, often within a few days. Dr. Jeffer just talked about colon surgery. The first 2 people we did robotic surgery to take out somebody's section of their colon. It used to be a 5 to 8 day stay in the hospital. The first 2 patients I had with that, the day after the surgery wanted to go home. They already were up walking the night of the surgery. Their bowels were active. They were eating. They wanted to go home on day 1. I said, I've never seen anybody home on day 1 before, but they went home on day 2. And the majority of people go home on day 2 or 3 after that amazing improvement in this major surgery. So we want to get you back to whatever matters you most. Taking care of your kids, getting back to your hobbies, getting back to your job much sooner. So what's a hernia? Hernia occurs when tissue, something inside pushes through an opening in the muscles of your abdomen or your groin, which is the lower part of your abdomen. So this is showing somebody sawn off right down the side, looking at the side view. So inguinal or groin region shows a little bulge down that groin area. Men or women, women get these as well, not just men. Or ventral hernia, a big word for the front part of your abdomen. So anywhere from your ribs down to the lower abdomen, often around the belly button or the previous scar. There's a bulge of either inside fat or intestines through the front of your abdomen. And these are some things that might lead to you knowing about the hernia. But we think a lot of hernias, especially the ones in the groin area, are probably born with a weakness there, because children get these too. Babies sometimes are born with them. But you might start to get symptoms after some heavy lifting, a job that requires you to do a lot of that exertion. Prior surgery can weaken the muscles. Chronic coughing, an injury to the bowel. Pregnancy is a common risk for women, as that tummy gets stretched out and makes those muscles weaker. Some of the symptoms from a hernia are pain in the area where the swelling is, a bulging, and sometimes just a heaviness or weakness. Some people don't even know they have a hernia. They just feel a little pressure or weakness, or a doctor says, hey, you got a hernia you didn't even know about. So how are they diagnosed? Well, we say history in medicine, what you tell us. So sometimes you tell us exactly what's happening. We can tell when you walk in the door. People often say, hey, I've got a hernia. I know what it is. I looked it up on the internet. I talked to my friend. Physical exam may be, like I said, on a school physical for a sport or college or Army physical, or your doctor maybe is doing your annual and find something there. Sometimes these other tests are done, not very often. They're just listed there for interest. We can ask questions about that later if you like. Ultrasound, CAT scan, MRI, pretty rarely used unless we're really unsure about something. What are your options? Well, you can watch and wait. Like we said, put it off until a better time. But sometimes you end up in the emergency room with a larger, more painful hernia on an inconvenient Christmas Eve or during a vacation, wishing you'd done it last spring. You can wear a hernia belt, but nobody in this room is going to tell you to do that. They're not safe. They're not very effective. They don't work very well unless you're somebody who's just so ill, so many medical problems you just can't tolerate having anesthesia and going to sleep. We might consider it that, but it's not a very good solution. And then surgery. And the repair basics is a very simple diagram. It just shows you here's the bulge, and then during the surgery we push things back where they belong, usually with an open incision. And then we put a piece of mesh, which is kind of small here, but you'll see a little without a liner, where there's a piece of mesh or screen material on the inside to cover up that defect. So that's always required open incisions for one about the belly button or down the middle from a scar, or in the groin area. For many years we had to open you up, push things back up, back inside, put stitches or put a mesh or piece of material to hold that in. A screen, some people say, mesh material. And everybody stays up nights watching those commercials about the hernia risks. So if you want to ask me about those later, mesh is critical and important and always used by every good surgeon. So we've talked about that if you have questions. But open hernia repair, there's lots of benefits to us as surgeons. We get our hands and our big tools inside there. It's often easier to free up things that are stuck, adhesions. It's better for a larger, more complex hernia, a larger sized person. The risk, though, there's more risk of bleeding. We're cutting more things to get there. There's much more pain, post-operative pain. Often a longer recovery with the bigger scar and a risk of hernia return, no matter which way we do it. Laparoscopic hernia repair, we've seen some of these incisions before. Use small cuts, place where we need them. Put those tools inside, do the work, and I don't spend a lot of time in here. The benefit there is you often go home the same day, outpatient surgery, smaller incisions, less pain, less bleeding. There are risks. We have to be careful because we might have an unseen injury to an organ. We may have to convert this to an open surgery if it's too difficult to do a regular open incision. Hernia can return, like I said, with either case, and it might be a longer anesthesia if it's a difficult one. And then robotic assisted, this is just trying to show you if you have a hernia in the middle, around your navel or somewhere from a previous scar, you'd have 3 little cuts on the side so we can see over there to see what we're doing. In the case of a groin hernia on one side or the other, we use 3 small cuts up here. The pointer instrument's down. If you look at that model back there, an actual robot, you might get a better idea how those things are pointed towards where we're doing the work. Benefits, this is laparoscopic hernia repair. I'll get on that title. Should be robotic. So this is, again, it's something like laparoscopic, less pain or bleeding, but much improved vision. We can see much better because we have this 3-dimensional camera up close. Improved dexterity because we got tools that work just like our hands inside. You can see that if you play around with this. Much better dexterity. Easier placing the sutures, putting stitches in and actually putting those in place. And then less likelihood in most of our experience that we'll have to open you up because we can do more things with those small incisions. Risks are about the same as we mentioned for laparoscopy. So you can ask questions at the end. We want to get to your questions here. We just got a brief presentation now on gallbladder. How many scars do you need? A lot of people have had this scar over the years, the big open surgery incision. Many people have had laparoscopic surgery with 4 small cuts. With Da Vinci surgery, you can do multiple incisions with 4 like this, or 4 right across the abdomen. And then with the single site, which is something we're not showing up there today, but a very amazing innovation, we can make 1 single incision in your navel, and we can put 4 tools inside you and do the whole operation through that single incision. And there are surgeons in the country who are doing hysterectomy now with a single incision, taking out kidneys with a single incision, parts of kidneys, and other things. So this is another one of the advancements that this technology allows us. So this is the video, which I just pushed the button and wait a second, right? This will give you a little better idea how this single site works. And before we start that, just imagine if you're anybody that's that knits here or crochets. You got anybody that knits anymore? My mom does. So you know you've got imagine if your 2 knitting needles, instead of working side by side, you had to hold them right close together and try to knit. You couldn't get those tips apart. Or if you drilled the top of your hood of your car to change the spark plugs, but your 2 holes are right next to each other, you wouldn't be able to get your tools in there working side by side because they bang against each other. So in laparoscopic surgery, we put incisions, several different openings so we can get things spread away apart. With a single incision, how do you do that? How do you get those things spread apart? Because everything's banging up against each other. This will show you a little better how that works.
If you're facing gallbladder surgery, ask about all types of surgery available, including minimally invasive surgery through 1 belly button incision using traditional laparoscopy or robotically assisted Da Vinci surgery. Using Da Vinci and its single-site technology, doctors have a 3D HD view inside your body and operate with precise movements.
No blood, don't worry.
To perform this procedure, your surgeon first gently clamps the gallbladder, then the cystic duct is carefully cut. Next, the gallbladder is freed from the liver, and finally it's removed from your body. The end result, virtually scar-free surgery.
Takes a few more minutes than that. This shows you from the outside what looks like one incision, one little silicone rubber ring in your belly button that we stretch out. So instead of 4 separate incisions, you got one with a scar inside your navel. You know, these 4 precision instruments, little tiny, actually go to that one opening. And then what happens is on the inside, I guess this diagram will show that they crisscross on the inside. Those 2 tools crisscross, and I can't explain what the engineers have, so that those 2 devices are spread way apart. And as he said, Dr. Clancy said at the beginning, the computer reassigns the right hand to the left hand. Don't ask me to explain it. So while I'm working over that console, I think my right hand's doing this, my left hand's doing that, and actually it's the completely opposite hand that's doing it. The left hand doesn't know what the right hand's doing. They're actually switching. It allows me to work just like I always work with laparoscopy, to get those 2 devices far apart. So I got that spread, and can do that with 1 incision. So you end up with virtually no scar. And we'll just end with this. For all your outstanding surgeons you heard tonight, the ideal for a surgeon from the 1400s was once said to be that you needed to have the eye of an eagle, the heart of a lion, and the hands of a woman. And the reason was the eye of an eagle to see well, which the Da Vinci allows us to see things really well up close with 3-dimensional vision, much better than we could before. The heart of a lion to be courageous to do things we couldn't do before, bravely and confidently. And in the hands of a woman, I don't quite qualify, in case anybody noticed. But those nice slender hands now get inside with those very miniaturized little instruments and these very precise things that people used to say only a woman's fine hands can do in an operating room. So, great decision with that small incision.